Oh, look who's here. Can somebody say something? Because I can't hear you guys.
Can you hear me?
Yeah, can't hear that. What if try again.
Hello.
Okay, there you go. I had to put you in the TV. Okay.
Hello.
Hello.
French, so-called French. English. Hello. It's a sitcom.
All right, I'm gonna share this and make it full screen. All right, do you see the full screen?
Half screen.
No, yeah, it's just a half.
Yeah, it looks funky.
Okay. It's because I'm on the TV and I'm on the Zoom, and that doesn't seem to go together. So I'm gonna have to abort the TV. All right. Yeah, Mia can put it over there maybe. Okay. Okay. Stop share. All right, now do you see the full screen of the molecular?
Yes.
I'm just going to sit behind you.
Yeah, sounds good. All right, can somebody again out there say something so I could see if I could hear you?
Head and neck is awesome.
Oh, yes, it is. Okay, great. Cool. All right, I'll have the chat open in case anybody wants to type in there. And thanks everybody for coming. And all right, hi, Dan. All right, so we here see a lot of thyroids. So just as a baseline, over 300 thyroidectomies come per year. I don't know what it is like for thyroid FNAs, but if you guys have that information.
You know that?
I know it.
Yeah, because you have a list.
Oh, I have a list, but I don't have it in my brain. So anyway, a lot. Yeah, so there's been some kind of, I don't know, just difficulty in understanding these molecular tests that come on the thyroid FNAs because they're challenging and they sometimes don't make any sense. And so I just sort of wanted to go over them and figure out how we can best kind of combine our practices. And so the cool thing is, our thyroidectomy diagnoses are going to be extremely homogeneous because it's basically me. And if it's not me, it's her. So we have a very focused framework about how we think about the permanent tissue, which can help reflect how we think about the FNA and vice versa, right? So it's sort of a nice combined effort. So as you know, we're working, on the FNA histologic Bethesda diagnoses, ranging anywhere from unsatisfactory to malignant. And so what we did based on our historic data was we sort of looked at what our rates of malignancy were compared to what the Bethesda rates of malignancy were, just as a baseline to make sure that we're sort of in the groove. And we essentially are. Our reported rates are within what's expected, so fine. The interesting thing is, which will kind of become important when you think about the molecular, when we take what we consider FLUS, follicular lesion of undetermined significance, which is mostly architectural sort of microfollicles, rather than significant nuclear atypia, that risk of malignancy is super low. That's like 7 to 8%, which is just higher than benign. When you take AUS, which is more nuclear atypia, which makes you think about PTC, right? That's much higher. That's more like 33%, which is more like follicular neoplasm, suspicious for follicular neoplasm. So we've decided here that Bethesda 3 is not homogeneous. and it's more likely separated into these two groups, which reflects the underlying molecular and biologic behavior of these neoplasms, which we'll get to. Okay, so then what happens after FNA, right? Of course, patients will either undergo observation if it's benign and they're asymptomatic, or they will undergo some kind of surgery. A lobectomy tends to happen either in the diagnostic setting when there needs to be a definitive diagnosis of an indeterminate nodule, which is generally Bethesda 3, 4, and sometimes 5, but usually 5 is considered almost 6. Or if it's a known carcinoma that is very low risk, small, no nodes, this patient may not in fact need radioactive iodine therapy, so they can spare the contralateral lobe and just do a unilateral lobectomy. The patient will undergo total, for example, if they need symptomatic relief for either non-neoplastic disease, like a true giant nodular goiter or Graves or Hashimoto's, or treatment of a higher risk known carcinoma that is anticipated to need radioactive iodine. Therefore, they need to remove the entire gland, right? So if you think about it, the only reason to remove the entire thyroid gland in any patient with a cancer is to give them radioactive iodine. If you are not going to give them radioactive iodine, you do not need to do it. If you decide later you need to give them radioactive iodine, you need to take the whole thing out. One needs to take the whole thing out, because otherwise it will just sink all the iodine and it won't kill any of the circulating or the residual tumor cells. So just to put that in perspective. So when we get down to it for the molecular, basically if you're dealing with Bethesda 3, 4, and sometimes 5, these will generally get sent for molecular testing as quote unquote indeterminates. And so the 3 companies that we in the US send to are Veracyte, which is better known as Afirma, Interpace, which we send to, which the 2 tests are known as ThyGenX and Thyramir, and then ThyroSeq out of Pittsburgh. So there's a nice review last year by Mishia Nicino. He writes all these reviews. He's like the dude of thyroid reviews. And he has nicely kind of put the molecular tests into these 3 broad groups, which I think is actually quite good. 1, you have a high probability of malignancy, and you should either consider a total thyroidectomy, if not at least a lobectomy. Something that's extremely low probability of malignancy that we are fairly convinced is benign, and then sort of still everything else that still remains in this indeterminate category. And so all of these 3 commercial molecular tests have some kind of gene, messenger RNA, or microRNA expression profile that sorts these lesions into those with patterns of gene expression that are more commonly seen in benign nodules and patterns of gene expression that are more commonly seen in malignant nodules. These are not, you can look through all of the messenger and microRNAs that they have on their thing, but usually it's kind of behind the scenes, and we don't like delve into the depth of this. But what they are called, ThyroSeq calls it a genomic classifier. Interpace calls it Thyramir for microRNA. Afirma calls it a genomic sequencing classifier. So the names are all different, but the concept is all the same, all right? The second part of all of these is some kind of next-gen sequencing for specific mutations or fusions that are present in thyroid neoplasms. ThyroSeq just calls it their sequencing. Interpace calls it ThyGenNext for next generation, and Afirma calls it their Expression Atlas XA. So with those in mind, this is what they do. So this is from that paper. Essentially, they vary in the amounts of genes or fusions that they look for in the micro versus messenger RNA, but all of them have some kind of QC that tell you, yes, these are follicular cells, or these are parathyroid cells, or this is not of follicular derivation, but it is a thyroid, perhaps medullary, like for a RET mutation example, for example. So they're mainly saying, is this thyroid, not parathyroid, and not medullary, right? If not, then all of these above things are performed. Just FYI, I think the only one that requires the tissue to be submitted in their proprietary solution is Afirma. Both ThyroSeq and Interpace can use the solution that they provide you for the pass that comes out of the patient, right? Or you can send them FFPE from a thyroidectomy, or you can send them FFPE from a cell block, or you can send them, or whatever you fix cell blocks in. Do you fix them in 4-on-1? Cytolite. So Cytolite fixed cell blocks, and smears. So you can scrape off of the actual diff quick smear. All right. So much more flexible in terms of what you can send to thyroid interface, which is one of the reasons why we did not choose Afirma here, because we did not want to have to be dealing with refrigerated vials and the lack of ability to send smears and blocks, etc. Okay. Does anybody have thoughts or comments or questions so far?
In the beginning, Afirma was actually asking us also to send the slides that they can make diagnosis. And I think they got away with that.
They did. They got away with that. So they now are accepting the cytopathologic diagnoses of the referring institution and only receiving the sample in fixative or whatever. Okay. All right. So when you have a quote unquote indeterminate cytology, and I use this phrase because that's what's used in the clinical world, broad strokes, if you have one of the gene expression classifiers that's telling you benign, this means there's a really high chance of the final surgical pathology being benign. Most say 5% or less, 4, 5, 6%, which is basically what Bethesda says is, okay for a benign Bethesda. If you have the gene or RNA expression classifier that is not benign, this could end up being benign or malignant. So the issue here is that Afirma calls these suspicious, which doesn't mean that it's suspicious for malignancy in terms of 70, 80, 90% risk. It's still like half and half. It's still 50%. It's still a coin toss, right? So when you read Afirma suspicious, I don't actually find that helpful. That has been confusing. When Afirma first started, years ago, I've read these reports of surgeons saying, oh, Afirma was suspicious, therefore it's highly suspicious for cancer, therefore I got to do a total. Like that's just not true. It's just not true. It only means not overtly benign. Okay. All right. So then rolling the expression classifiers in with the mutations or fusions is arguably the most important thing that you can do. And so always look at that report and ask, what are they saying is positive, right? What are they saying is worrisome? If they're saying, all right, there are no mutations and no fusions, then you're back to that previous chart. You're only dealing with the gene expression classifier, either benign or not benign. All right, so again, something or nothing, right? So this is still an indeterminate category down here at the bottom. Okay, but if you have a mutation or a fusion present, arguably this is going to be more important than the expression classifier in terms of your framework for deciding whether you think this has a probability of being benign or malignant. So if you see something like a BRAF V600E, a BRAF fusion, an NTRK fusion, or a RET fusion, these are essentially only present in papillary thyroid carcinomas and should really be considered biologically malignant. If you have something else that is a mutation or a fusion found in a more follicular neoplasm pattern, like a RAS, H, N, or K, like a BRAF non-V600E, so anything K601, that is generally a non-PTC locus, okay? Usually it's K601E, but it can be K601 anything. Pax8 PPAR gamma, right? So these are the three main ones that you may see to determine that this is a follicular neoplasm. Again, a follicular neoplasm may be benign or malignant and still needs resection to determine whether it has capsular or vascular invasion or not. Does that all make sense? So the summary from these outcomes are, if you have a negative mutation panel and a negative expression profile, this is very significantly putting it into a benign category, right? So you've now taken a cytologically indeterminate nodule where the risk is anywhere from 10 to 40 to 60 to 70% to an effectively benign nodule where the risk is less than 5. So these patients may not opt for surgery. If you have a positive mutation that is diagnostic of a follicular neoplasm, which are the ones we already mentioned, these can be a follicular adenoma, a NIFT-P, a follicular carcinoma. Diagnostic lobectomy is going to be required for definitive diagnosis. If you have a positive mutation of carcinoma, that's a BRAF V600E, like I said, RET fusion, NTRK fusion, BRAF fusion, definitely they will require surgery, either a lobe or a total. On the other hand, a RET mutation, right, one of the ones that we see in medullary, again, specific for medullary, needs to come out. Then there are these others that we run into from time to time, like TP53 or TERT promoter. these are considered relatively higher risk mutations that are only infrequently found in benign lesions. So always take these with caution, because generally these patients should also undergo surgery because they have a quite high risk of malignancy. They can be seen on their own or in combination with something like a BRAF or with something like a RAS. Okay, these are generally secondary acquired on top of whatever that bottom line driver is. If you have a positive gene expression profile, but no specific point mutations or fusions, you're again sort of at a loss. We have no direction as to whether this is benign, whether this is a follicular neoplasm, or whether this is some kind of carcinoma, but it should come out because something in those genes have been tagged as worrisome. And more often than not, these end up being some variant of papillary thyroid carcinoma that just has a no known driver. That's mostly what we've seen. So to summarize again, the spectrum of what we can see in chart format, when you see the TP53 or the TERT promoter alone, or the TERT with BRAF or the TERT with RAS, the TERT plus are thought to act as synchronous drivers, meaning they make the cancer even worse. So these two together are extra bad than either alone. What is really not known is, we know papillary and follicular can transform to poorly diff, and they can all transform to undiff or anaplastic. But what we really don't know is if follicular adenomas or NIFT-Ps, for example, can transform to carcinoma. There is a theory out there in the world that they can. Therefore, if you have a follicular neoplasm, mutation on your FNA, basically they have to come out not because they're malignant, but because they have a small chance of being malignant. And we found here that the chance, in fact, is present, but small, right? Because your pretest probability of a follicular neoplasm being benign or malignant is much favoring it being benign, right? How many follicular carcinomas are there compared to follicular adenomas? In relationship, not many, right? So when you see one of these RASs, BRAF K601s or PAX8 PPAR, chances are it's going to be benign, especially if it's small, but there's always a chance of it being some kind of follicular type carcinoma. The last one that we know about, recently discovered, are these GLIS fusion genes. And we think that these are only being evaluated for on the ThyroSeq panel because Nikiforov described them. But hyalinizing trabecular tumor has now been shown to have GLIS fusions. And so this is, again, one of these indolent, like probably a NIFT-P type of tumor that is an indeterminate malignant potential, not called a benign adenoma, not called a malignant carcinoma, but called a tumor/neoplasm. So that's the only new thing that we know. If you want, to go into more detail, BRAF V600E, we think about in the conventional papillary carcinomas, 85% of our papillary carcinomas here have BRAF. So the overwhelming majority have BRAF V600E mutations. But when we have found something like a RET PTC fusion, it's not called PTC anymore. It's called like CCDC6 or some horrible name like that. So RET CCDC6 is PTC. NTRK fusions are usually some variant of papillary carcinoma, but we can also see NTRK fusions in the salivary type secretory carcinomas that arise in the salivary gland that are PAX8 and TTF1 negative. All right, so just keep that in mind. And then lastly, the other BRAF fusions are thought to be more like conventional papillary carcinomas, right? So BRAF non-V600E mutation, more specifically BRAF K601, is going to be your follicular neoplasm. BRAF fusion is thought to be more like papillary thyroid carcinomas. And you may say, how the hell do we know all this? Well, most of this information came from the TCGA study, which was pretty great in as much as it had, almost 500 carcinomas, and it sorted them based on not just mutations, but all their background, deep genome that we don't generally look at every day. And they sorted them into these tumors with a score, 1 to 100 or whatever. And they clustered into those that had more of a BRAF V600E like score and those that had more of a RAS-like score. And lo and behold, the ones that resembled the conventional PTCs with BRAF V600E, right, are the BRAF fusions, are the RET fusions, and are the NTRKs. You can see how they line up on the left side of that pole, right? Whereas the HN and KRAS cluster with the BRAF other mutations and cluster with the PPAR gamma fusions. So that's why we think we know what these look like. And I will trust this genetic profile if I am uncertain in a case, because there's background genomic information buried in here that we can't necessarily see on H&E. And so I trust this paper. If you ever see a weird mutation that you don't know what it is, I always go to this paper, and generally it's reported somewhere in there or in the supplementary material if there's ever confusion. You know, on the bottom line are these more rarely seen things like MET, ALK, you know, E1, EIF, 1AX. We don't see those very often, so I haven't mentioned them here, but they're in this paper. So, you know, just to recapitulate, you know, if something's not a carcinoma of follicular cells or a tumor of follicular cells, right, we can certainly have the weird things like the medullary thyroid carcinomas or the salivary type carcinomas or the thymic type of carcinomas that are less common and not really focused on here, right? But we've sort of focused on if it's of a follicular cell origin, does it fall into one of these well-differentiated neoplastic categories, either being a follicular neoplasm or a papillary carcinoma, or does it have the risk of being one of these higher grade categories like a poorly diff or an undiff with the P53 and the promoter? So that's kind of how I think about these. So when we see these molecular reports, please try to include as much detail as you can, sort of for our posterity, because sometimes the reports are attached with, you know, the requisition. Sometimes we're digging for them in the charts. And when you know, the world explodes and Epic Beaker dies, like all of those scanned records are going to be gone, right? So well, I guess COPATH would be gone too, so it's useless. But in any event, if you want to help everyone out down the road, you can please put that information in the comment. And so certainly what company is doing the test, what are the specific molecular findings, both in terms of what did that gene or RNA expression classifier tell you, and what specific mutations or fusions were found, because that will really help dictate for the clinician how to approach this case. And so the most recent example that I think was super interesting and kind of spurred this was there was a Blair case where it was, very nicely reported that there was a BRAF mutation on the outside. And I was like, oh, well, that's, you know, probably carcinoma patient. Oh, it's 3 centimeters. They probably need a total. And I was like, well, let's just look. And so we pulled up the report and it was a BRAF K601. And I was like, oh, Blair, no, this is completely different. Like the patient probably just needs a lobe or a, you know, hemi, like, you know, because we don't know if it's malignant or not. So those specific things can really help guide the surgical procedure for these patients and can help us as a group better, I don't know, console, that's what's the word I'm looking for. Counsel, just put the X on the wrong syllable, better counsel the surgeons for what to do clinically, because, you know, there is a monthly thyroid tumor board. These things come up, they are smart people and they ask a lot about the molecular. And so if molecular is done on the FNA, we generally will not go ahead and continue to do it on the FFPE tissue if there's ever a question. So that's very, very helpful, not only for pre-surgical management, but sometimes also for post-surgical triage of these patients if there's a presence of, you know, anything high risk for treatment or whatever. So that reported numerical risk of malignancy where it's like your risk is between 35 and 85%. Like, I don't find that helpful because I don't know what that means. I find looking at the actual specific mutation helpful and looking at exactly if that gene expression profile, which is supposed to be, you know, binomial, is it positive or negative kind of thing. So I'm always happy to go over these with you if the report is unclear, because, you know, it's we write on these, we try to do scholarly projects on these and make them better, right? Make the understanding of these better. So the more I see, the better it is for me to learn, and hopefully the better it is for the patient. So hopefully that was somewhat helpful. I'm sure there are comments or questions. Sorry, I may have missed. Did you mention NTRAC dances? Oh, yeah. So, oops. So yeah, that Peter Sadow et al. Kind of wrote a really nice paper on the NTRAC fusions and how these are quite follicular patterned neoplasms, but with, you know, some extent of papillary nuclei, highly invasive, often high, you know, not high grade, but sort of aggressive, potentially aggressive carcinomas. What else?
In our comments, we call it floss on the outside, it did molecular, and it finds whatever mutation.
Mhm.
So we then need to also go further and interpret that based on our knowledge, because I mean, the case you just described, the one of the last week, right? Had we had said positive for a BRAF mutation, but very honestly, I had no idea that that difference in B600E versus another one was relevant. I would have just called it BRAF, so this is BTC, right? And so, because if that's the case, then quite honestly, I will be showing every single molecular to you and say, Nicole, yes or no, and that's the way it's going to be otherwise, right?
Yeah, no, I mean, that would be fine. I think the most you can do is put the specific, but no, maybe the least you can do is put the specific mutation in there, like K601 insertion deletion.
Yeah.
Then if the clinician has a question, they'll call me, so you don't have to worry about it most likely. But there are some out there that are quite savvy, like Sarni is like, he knows exactly what everything means and he won't have a question, he'll just know what to do with it. So if you don't know what a molecular mutation means, come and find me, we can work through it. And if we think we need to put something in the report, like this supports a diagnosis of a follicular neoplasm rather than a conventional PTC, we could do something like that. Does that make sense?
Yeah, perfect.
You know, there's something about putting their expression about risk. Say they say high risk,
Right.
and then we immediately put down that it's mutation that's actually low risk.
Right.
So I feel weird about
Right.
putting that in a note.
Right. So
You don't do that.
you can leave that percentage out. If you put the mutation in, I would urge you, if you feel uncomfortable with the percentage, just leave the percentage out. I generally don't put the percentage in. I say gene expression profile was negative and there's a RAS mutation, period.
That's specific.
Yeah, HRAS K60, you know, Q61R or whatever. Yes, exactly.
For the same reason, we do not include in Bethesda percentages of malignancies because we do not believe that that's correct. And I know that some outside people do that because when you read their diagnosis, they tell you Bethesda category, whatever, 2, whatever percentage malignant. We don't do that because we really don't believe that these are correct numbers. Therefore, we don't want any kind of misleading ideas in people's head.
Right.
As long as you just put from the report what the gene is, that's pretty good because people who deal with this know what these things mean, they will understand. You don't need to interpret, you don't need to say anything else, just put it there and most of them will know what to do.
I think because I sometimes get from Porter Hospital in Valparaiso, Indiana, we get core biopsies of thyroid. It comes from like no other hospital in the entire world, right? But sometimes they send it. And so I get the report too, same problem. And I think some probably have slipped through the cracks, but I agree. I would just say the gene classifier is this, the mutation is specifically this, period, and don't report the percentage. Yeah.
So can I ask you how, if the molecular report is attached to the outside paperwork, you put a comment.
Yeah.
And how far should we go if it's not attached?
Yeah. So if it doesn't say that they're going to be sending it, you know, you probably don't want to waste your time. If it says that they're going to be sending it and it's not attached, you could either, like, what would be great is if you were able to go into Epic and find it under the scanned documents or in the clinical note, because on the back end, it's helpful down the road. So when I'm signing out the thyroids, I'm not always reading the, scanned paperwork of the cyto, right? I'm reading what you guys say. And if you guys don't say that molecular was sent, I'm not going to go looking for it. But if you do say molecular was sent, I will go looking for it.
So can we just say the report with the molecular was sent?
Yes, you can say that. And then it'll at least be a clue down the road. If we need it, I can go looking for it. Outside. Yeah, because if you don't have time,
I mean, ours comes attached anyway.
Right.
ours comes attached anyway, right, but, right, and addended. But yeah, if you say, tissue was saved for molecular per outside report, or tissue was sent to molecular per outside report, great, then I can use that as a clue and we'll go find it. Yeah, that'd be helpful. NTRK fusion is important to report because there are now inhibitors that can be used to treat if needed. Yeah, so the targetable mutations in thyroid are certainly BRAF, V600E, and NTRK with the IBs, the NTRK inhibitors. Usually those are not frontline therapies. If it's a tumor of follicular cell origin, not one of the salivary secretories or whatever, it's a tumor of follicular cell origin and it needs treatment, they'll try radioactive iodine first. If it recurs or doesn't respond or becomes resistant, then they'll pursue the BRAF inhibitors or the NTRK inhibitors, generally, unless it's like a super aggressive carcinoma from the front. But yeah, that's a good point. What else? I know you have something to say.
I don't really, I just had an example from outside. I had the outside case where the sample was relatively cellular, mostly oncocytic cells. It was called either follicular neoplasm or suspicious for follicular neoplasm. And I couldn't really make up my mind. And I decided we decided to call the outside people and ask them if they would allow us to do molecular on the SME. And they said yes. And I called it AUS and we sent it. And I just yesterday got a report, which is very interesting. It's a RAS mutation with TERT. And I'm mentioning this because in my opinion, when we deal with oncocytic stuff, it's really, really hard to predict. And this is my maybe second time that I was almost considering calling something benign. And then I didn't want to be so different than the outside. I would call AUS and send it for molecular. And I got very surprising molecular finding. Therefore, I think with oncocytic tumors, it's really tough.
Yeah.
And once I see, I think one case was Dr. Lasserat case where we also had issues what to call it, because you cannot call them follicular neoplasm because they don't come really in the follicles, but they are all oncocytes and sometimes very atypical ones. And it's sometimes not even so cellular. And I think these kind of oncocytic lesions are very problematic for us. And I would like to actually do some study to see how these oncocytic things work, because more often than not, I was totally surprised. I mean, that case that came yesterday was total shock for me again.
Yeah, and yeah, so I mean, even in the WHO understanding of Hürthle cell neoplasms, they're like now a completely separate entity from follicular neoplasms because they are thought to be biologically different. They have mitochondrial DNA mutations, they have copy number alterations, they occasionally, but not frequently, have RAS or the PPAR gammas. And so they're like Hürthle cell is a thing now that's neither follicular nor papillary. So yeah, if that's present on the cytologic features, that's also sometimes helpful to know.
And that's why now I tend, whatever is purely oncocytic, I tend to just declare something.
Right, Hürthle cell
And-
lesion.
And send it for molecular because, as I said, it's really unpredictable.
Sometimes it's just a big nodule in Hashimoto's, and sometimes it's a freaking poorly differentiated Hürthle cell carcinoma.
Yeah, sometimes awfully atypical ones are nothing, and then the ones that are very kind of blandish, they have tons of stuff. I mean, it's very scary. Oncocytic ones. Anyway, that one is coming your way.
Great.
I assume it's going,
You got another one too. You got a new one.
I have a new one.
Yeah, was it yesterday?
I
It was
The
a
personal
personal consult? You got a new one.
Oh, yeah,
Oh,
but,
cool.
yeah, I get these personal consults from some guy in Michigan. And
So that's
never met him,
like-
never met him in my life, but I swear I got like at least 50 thyroids from him. I suppose he's,
It'd be interesting to see what that.
the thing is, this is just going to be, I call that suspicious for follicular neoplasm Hürthle cell type, because as you can imagine, I'm very worried about these things. And this one looked very atypical, like humongous nuclei, and well, but they don't have molecular, and he usually tells me if he's collected for molecular. He didn't say this time that he has anything for molecular.
Yeah.
But yeah, I tend not to dismiss those oncocytic, pure oncocytic ones anymore.
Yeah, it's interesting. Well, we're getting this, Blair resected that BRAF K601, I think, on Monday. So we're gonna get it. But it's interesting because, you know, ThyroSeq reports that as a very high risk of malignancy, because probably where were all the final diagnoses at Pittsburgh done? They were done by Lavosi. So everything's cancer to her. Ricardo, you probably know. So like, that's why I don't trust those, because when you have one pathologist that's very aggressive, skewing those numbers to calling everything malignant, and then your pathologist down the road is like us and more aggressively benign, then those numbers are essentially meaningless. Yeah.
Are you still sending to Interpace exclusively?
Yeah. You?
No, all three are possible depending on the situation.
And in what situation would you choose one over the other, may I ask?
We usually leave it up to the endocrine surgeon or endocrinologist who did the FNA.
Okay.
But yeah, that table from the review comparing the three was actually pretty impressive for me for ThyroSeq. They have, over 1,000 different variants and stuff.
Yeah, no, they do a lot. Cool.
Okay,
Awesome. What else?
Thank you.
Mhm.
you can always ask Nicole.
Yes, please do. I find this stuff so interesting. Like, it's fascinating. Thanks. And we'll have Perry tell us where she puts the recording on the M drive.
I'll just say, should I just put it with the regular lecture?
Sure. Okay.
Thank you.